Hello, everyone. Good morning, good afternoon, and good evening, wherever you're joining from. Thank you for joining the February edition of Get Webinar series. We are glad to have you here. My name is Faith Omalade Adebayo, and I'm a research and project officer at Get Consortium. And I'm delighted to moderate today's section. So if you're joining us, please introduce yourself in the chat box. Introduce yourself in the chat box. So good day, everyone, once again, and a very warm welcome to the Get February webinar 2026. Um, like I said, my name is Faith Omalade Adebayo, and I'll be your moderator for today's section. Today's topic is leveraging public health intelligence for early warning, preparedness, and health security in Africa. So whether you're joining us from Africa or from other regions of the world, we sincerely appreciate your time and participation. Permit me to welcome you again on behalf of the Chief Operating Officer of GET Consortium, Dr. Ayodotun Babadoye, who is unavoidably absent for today's webinar. He was supposed to be our moderator, but due to other engagements, he is unable to join. However, if he joins us towards the end of the webinar, he would still address us. So let me begin by briefly introducing the Global Emerging Pathogens Treatment Consortium, GET. GET is an African-led organization committed to strengthening biosecurity, preparedness, and response system across the continent through collaboration, research, and policy dialogue. And today's webinar is conveyed to facilitate alignment between global frameworks and African realities with focus on how public health intelligence can strengthen early warning system, preparedness mechanism, and ultimately health security across Africa. If you have your colleagues that are here to join, please do reach out to them and tell them the webinar has started. And we have our stellar lineup of speakers who will be discussing with us expertly on this topic of discussion. We all recognize that infectious disease threats are becoming more frequent and a bit more complex, which is why early warning is no longer simply about detecting outbreaks. It is now about integrating multiple data streams. It is about conducting structured risk assessment. It is about translating intelligence into decision making, into policies, and it is also about ensuring that systems are institutionalized and not reactive. So this afternoon rather, we have our speakers, and I will be listing their names right now. We have Dr. George Benjamin, we have Dr. Rockwell, we have Dr. Chinwe, we have Dr. Ifeyiwa Aniebo. Before we go ahead, I would like to mention a few housekeeping rules. Kindly introduce yourself in the chat box. Let us know where you're joining from. And also, as you do that, we would love to hear from you. What prompted you to join today's webinar? What prompted you to join today's webinar? Where did you hear about the webinar? And what are you hoping to take away from this section? We would love to hear from you in the chat box. Please use the chat box to drop your reflections, your name, wherever you're joining us from, what prompted you to join the webinar, and what you're hoping to take away from this session. Also, please use the Q&A box for your questions during the presentations of our speakers, and it will be addressed after the presentations. This session is being recorded and it will be uploaded on our YouTube channel at Get Africa at the end of the webinar. Certificates of participation will be shared to all registered participants. So if you know you are joining with an anonymous link, you could change the name from webinar participant to your name so we can have a record of you at our back end. Now, it's my pleasure to introduce our first distinguished speaker for today, Dr. Georges Benjamin. Is an executive director of the American Public Health Association. And Dr. Benjamin on will be speaking on public health intelligence and health securities, global priorities, challenges, and opportunities. Before we hand over the mic to Dr. Benjamin, permit me to read his biography. Georges Benjamin is a well-known health policy leader, practitioner, and administrator. He currently serves as the Chief Executive Officer of the American Public Health Association, the nation's oldest and largest organization of public health professionals. He is a former Secretary for Health for the state of Maryland, where he ran the Department of Health and Mental Hygiene, a $4.5 billion agency. Dr. Benjamin is a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He is an elected member of the National Academy of Medicine. Dr. Benjamin brings a global leader perspective to this discussion, and he will be helping us frame why public health intelligence matters now more than ever in an increasing interconnected world. So we are glad to have Dr. Benjamin in our midst. It's a privilege. The floor is now yours, Dr. Benjamin. Thank you.
Faith, thank you very much for having me this morning. And let me bring my slides up here. Hopefully you can all see those. So, well, thank you very, very much. Let me just say that to start, I don't have any financial disclosure or conflicts of interest with my presentation today. I did use AI searches to do some research and create some slide content. So I want to firstly disclose that this morning. Um, it's actually kind of a neat tool, actually. Um, with that, the 10th United States Surgeon General of our Public Health Service, um, several years ago, at the height of our using antibiotics and before a lot of antibiotic resistance, was trying to pivot. And he made this statement that it's time to close the books on infectious diseases, declare the war against pestilence won, and to shift national resources to such things as chronic problems such as heart disease and cancer. Well, you know, um, he couldn't have been more wrong. you know, um, Certainly antibiotic resistance has become an enormous plague that we're all trying to address. But we've had simply an explosion in emerging and re-emerging infectious diseases around the world um, over the last many, many years. And and then, of course, we ended up with COVID-19 and bird flu, which is popping up all over the country right now. Um, and in fact, many other nations have bird flu. And then the reemergence of old diseases, measles as an example, such that many nations are now beginning to lose their measles elimination status because of the reemergence of measles, mostly because of the reduction in vaccinations because of vaccine skepticism around the world. And the United States, while we've not yet lost that elimination status, are teetering on the edge of losing that, as many of our folks in Europe have already done. I thought I would start by just reminding us what public health intelligence is, and that it is the systematic collection and analysis of data from a diverse source, both health and non-health data sets. And what it really serves as an early warning system that supports, hopefully, evidence-based decision making for health protection and health improvement across the world. And it really is a very, very important tool that we have. And particularly in this world in which we have so much data and so many big data systems, this is going to be a very important tool going forward in our public health protection efforts. This is a chart from colleagues that was published in 2024 in the British Medical Journal, which really talks about the core framework for public health intelligence and health security. First of all, we talk about detection using a range of evidence-based surveillance tools, interacting in a bi communication manner with our partners around the world, um, picking out those signals that are most important. Not necessarily all signals are important, but trying to pick out the most important signals at the most important times. And then, of course, you have to verify these data. Data that's unverifiable gives the old statement of garbage in and garbage out. So it's very important that we use collaborative processes to verify the data that we have. And then to understand what that data means. Sometimes it's just simply an interesting phenomenon, and sometimes it's of a high risk. So risk assessment is a very important component of what we do. And then reporting that out to make sure all the relevant groups know what those systems are. Um, and this is really the framework very much that the World Health Organization is using today. Now, we have had a lot of acute public health events reported under the international health regulations over the last several years, and this gives you a sense of the fact that unlike our Surgeon General said many years ago, very important infectious disease events of international importance are pretty prominent, enough to get on this graph. And then, as you all know, we've been very successful as a global community to amend the international health regulations. And just to remind you that they fundamentally provide a guiding framework for us to address infectious diseases in particular of international concern. And some of the changes that of the updated regulations included defining a pandemic emergency as a new category within those regulations in order to try to specifically point out that all pandemics are not equal, that there is certainly a need for a pandemic category of highest concern. And then the fact that each country needs to really set up a national authority to coordinate and implement these regulations across the different sectors. Because it was recognized that um, in every country, there really wasn't anyone really designated to pay attention to the international health regulations. And so this part of the reg basically asks every nation to set up that kind of authority. Obviously, equity and access is a core component of our views in public health. So the idea of embedding equity as a core principle across all aspects of what we do in terms of vaccines, medications, diagnostics, and even supporting the diversification of producing materials. As you know, during COVID, we learned a lot about what happens with people that have um, access to vaccines and therapeutics, and the fact that many of our developing countries and lower income colleagues did not have full access to many of the things that they needed during COVID, and we need to fix that as a global community. Thinking about financing mechanisms that are more effective. I'm embarrassed that the United States has pulled out of many of our efforts on the global stage, and I'm hoping that we can turn that around because it's going to be very important that we maintain a stable funding mechanism. But this was certainly recognized as important in the new international health regulations. And then finally, implementation of monitoring. A new state party committee to really um, narrow in and focus on overseeing compliance with the regulations. One of the things that had always been a complaint of the initial international health regulations is they really didn't have any teeth. There really wasn't a good compliance mechanisms. And I understand that many nations want to maintain their national sovereignty, but we really need to give up a little bit of our national sovereignty if we're serious about being able to coordinate activities as we go forward and share so that everybody is safe and protected. So that gets us to what I consider the central challenge for the world, which is the next generation public health intelligence system. And we want to structure and resource the world's public health intelligence systems to meet the strategic health protection and disease prevention needs in a globalized world, recognizing that infectious diseases do not respect geographical and national boundaries. So some of the priorities, and these priorities support WHO's 14 general programs of work that they've laid out for the next 3 years. The next 3 years. One, to strengthen early detection and rapid response is going to be very important as a priority. And really looking at all of the surveillance systems, recognizing that we have new artificial intelligence technology that's going to be important, and thinking about how we more effectively integrate those systems. We talked about risk assessment earlier, but doing that risk assessment much faster is going to be a real goal going forward. Thinking about a hub focus, putting together our hubs where we can do this collaborative work in a more effective manner. There are lots of nations now that are looking at ways to bring together intelligence hubs so that people can share data, both that data that needs to be handled confidentially and that data which doesn't need to be handled confidentially, and doing more surveillance of pathogens. And that even goes down at the genomic level, not just the old way when we simply just catalog the bugs. Thinking about key target hazards and threats, recognizing that there are certainly things like antibiotic resistance remains a major barrier to us being effective in controlling infectious diseases, and strengthening our surveillance for those diseases that, while they don't necessarily have um, significance in all nations, they do have targeted significance in certain nations. So, cholera, yellow fever, diphtheria, monkeypox, for example, are examples of those organisms. And then, of course, building capacity across all of our nations and all of our systems in order to make sure that we have both the workforce, the technological infrastructure, and that infrastructure can talk to one another in a meaningful way. Certainly, a One Health approach is important. I remember being as a health officer in Maryland the first time West Nile virus and Zika introduced itself in the United States. These were certainly diseases that illustrated the extreme importance of a One Health approach in the United States, at least. But we also have this around the world. Ebola is a great example where we need to do a much better job of understanding zoonotic diseases if we're going to get our hands around this. And of course, climate change is dramatically changing the ecosystem in which we all live. And in that matter, we're seeing new emerging diseases and even old diseases in places that have never seen those diseases before. Um, and of course, managing misinformation and disinformation remains a central challenge to all of us um, as we go forward because of the speed in which this bad information moves. And of course, the best way to deal with bad information is to flood the zone with good information. Um, so we have some challenges. We certainly have had to deal with this whole issue of inadequate international cooperation. And we really need to get over that. We need to find a better way for us to work and play well together. We have lots of separate data systems, surveillance systems. Again, they don't talk to one another. They're not interoperable in many ways. Um, some of that is by design, some of that is inadvertent. But we need to figure out ways to do that. By the way, the private sector has figured this out. Banks are able to share information. You're able to get money anywhere around the world in almost any currency that you want. The fact that the private sector and the business sector, hotels and commerce have been able to do this, we need to be able to do this more effectively in the health sector. Recognizing that the technology is there right now, but it continues to change. And that is a cost issue. The fact that the technology changes so quickly, upgrading that technology continues to be an issue. And even in the United States, where we, during COVID, we're still exchanging information by fax machines. Fax machines. That needs to stop. Um, we talked earlier about inadequate and unstable funding, and AI is both a challenge, for sure, because it um, undermines a lot of our privacy efforts, but it's also a tool that um, does do things that it hallucinates. It doesn't necessarily give you all the answers that you want. Again, it's an excellent example of garbage in and garbage out. Now, certainly there's several opportunities over the next several years. We do have the ability to make this system interoperable. The technology does exist. Um, and we do have the ability, particularly next generation genetic tools, to be able to truly be able to understand and rapidly identify infectious agents. That previously we had to do very exhaustive chemical tests to figure out to compare organisms, to figure what those organisms are out, to figure out the etiology of an outbreak. Um, and we have emerging, very robust tools to forecast diseases on an ongoing basis, for both prevention and early intervention. And while artificial intelligence is a challenge, it's also an opportunity, because it can do things much faster than we can, as individuals, in our silos. I think, the next generation public health system, we need to strengthen our statutory authorities. The International Health Organizations is the first start in that effort. We need to build vibrant and cross-societal partnerships. We often say that exchanging business cards in the middle of the disaster is a bad idea, so we need to get to know one another. So let me commend GET for having this webinar today, because this is an excellent opportunity for people to begin to know one another and share information so that they know who to contact in the middle of an emergency. Um, Making sure that all of our systems are accountable and certified. And again, we talked a lot about the importance of health equity throughout the enterprise. Um, I think that any successful integration model can be used to assess any threat. So certainly emerging or re-emerging infectious diseases, but just know that this model that we're talking about today can be used to address chronic diseases, severe weather, contamination of products, eliminating injury, even intentional events with terrorism and toxic exposure. So the model we're talking about today is not just a model that one can use for infectious diseases, but we can use it for the whole range of our public health enterprise. And then finally, Albert Einstein said something that I thought is present, and that is that not everything that counts can be counted, and not everything that can be counted counts. And so we need to remember that the data that is important, we need to utilize, and that there's a lot of stuff that we can count out there that we need to maintain our focus on what's important and not just count on things before for the ability to count them. With that, I'll thank you, and I'll turn it over to the next speaker.
Thank you very much, Dr. Georges, for that beautiful presentation. Thank you for starting from scratch. For people that don't know much about the topic, you started from the basic things and you went gradually. You mentioned a few things which I would like to highlight. You mentioned public health intelligence global priorities, which include strengthening early detection and rapid response. And this also includes enhancing surveillance system, integrating artificial intelligence and technology, and also rapid risk assessment. You also mentioned pandemic and epidemic intelligence, and you mentioned key target hazards and threats, capacity building and infrastructure, One Health approach, emerging issues. And finally, you mentioned that a successful public health integrated model can be used to address any health threats, which I believe is true, from emerging to re-emerging infectious disease to chronic disease, severe weather from climate change, terrorism, toxic exposure, injury pandemics, and so on. Thank you very much for that beautiful presentation. We appreciate you. Moving on, we would like to build on that global perspective and now turn on to institutional and technical frameworks shaping public health intelligence today. And to do that, we have in our midst Dr. Raquel Carrella from the WHO Hub for Pandemic and Epidemic Intelligence. Before I hand over the floor to her, I would like to welcome you if you are just joining. Kindly use the chat box to introduce yourself. Tell us wherever you're joining from and what is it that you hope to get from this webinar. She'll be speaking on WHO frameworks and innovations in public health intelligence for Africa. Dr. Rockwell is an epidemiologist at the WHO Hub for Pandemic and Epidemic Intelligence in Berlin. She holds a PhD in infections and global health from the University of Liverpool and completed a field epidemiology fellowship with the European Centre for Disease Prevention and Control. Her career spans emergency response and public health works across multiple regions, including Brazil, Sierra Leone, India, Guinea, Malta, and Angola. She has contributed to the response to a wide range of outbreaks, including Ebola, Zika, Marburg virus disease, COVID-19, and cholera. Since 2019, Dr. Carrella has served in the WHO Health Emergency Program across several duty stations. For the past 3 years, she has been based at the WHO Hub for Pandemic and Epidemic Intelligence in Berlin, where she leads projects and initiatives aimed at strengthening public health intelligence globally. Dr. Rucker will help us understand how global tools and innovations are being developed and what they mean for Africa health system. It's a privilege to have you in our midst. Thank you so much for honoring our invitation. Over to you.
Good morning, good afternoon, colleagues. Thank you very much, Faith, for this wonderful presentation. It's a real pleasure for me to be here with you all, and it's a real pleasure to be able to share some of our insights and some of our expertise around WHO frameworks and innovations in public health intelligence. Thank you again for the opportunity. I'm speaking to you from the WHO Hub for Pandemic and Epidemic Intelligence in Berlin. And over the next few minutes, I want to take you through a range of few frameworks and innovations that have been developed globally for public health intelligence, and specifically how some of those are already implemented in Africa and the potential for the future for experts and professionals in the African region. So to start, I would like to build on George's presentation and start on discussing how the public health intelligence function is not a new function. It's actually a core public health function responsible for identifying, collecting, connecting, synthesizing, analyzing, assessing, interpreting, and generating a wide range of information for actionable insights and disseminating this for informed and effective decision-making to protect and improve the health of the populations. And this is how the United Nations glossary of terminology defines it. And it basically means that public health intelligence is extremely important for global health security through rapid detection of public health threats, provision of evidence that supports timely public health action, improved preparedness to strengthen health systems, and supporting the One Health approach. But specifically, the context of the African region, it's very particular. And the way public health intelligence is conducted in the region, it's critical and very important, particularly given the high burden of public health threats that are emerging and re-emerging and spreading across many member states within the African region. There are frequent and very complex outbreaks and emergencies. And maybe here we can get some interaction from the participants to share with us some of the different outbreaks and epidemics you've been involved with in member states or in your country, because African countries have seen or are seeing outbreaks of cholera, mpox, Ebola, measles, anthrax, environmental health threats, including natural disasters like floods and droughts. And all of those have a high impact on lives, economies, and in the health systems of member states across the whole continent. And cross-border spread of some of these epidemics is also very common. The WHO integrated disease surveillance and response framework has been widely adopted across the region, but there is uneven implementation. And also, we are aware of the specific context that implies suboptimal all hazards, one health, interoperable surveillance systems. The guidance, the IDSR, Integrated Disease Surveillance Guidance and Response Guidance, promotes the use of open source intelligence and public health intelligence activities to strengthen surveillance across the continent. And one specific consideration that takes place across many countries in the African continent is that traditional media remains very important. Use of radio, television, newspapers. There's also a plethora of online media with relevant health-related information, including web news and blogs. Social media is also very used and another very important source of information for public health professionals, including Twitter, X, Facebook, Instagram, WhatsApp, many more. There is also scientific and great literature, reports coming from different governments and different agencies, and a range of digital platforms that can be used. And one consideration of this context is the importance of timeliness in detection of response, and public health intelligence facilitates this faster detection that is often much quicker than the formal reporting. Also, how public health intelligence has an all hazards approach in the region, capturing not just epidemics and infectious hazards, but also environmental and other non-infectious hazards. And also the importance of and the considerations around situational awareness, the tracking of rumors, the behaviors, the perceptions are also very much used for public health response. One of the main WHO frameworks and legal instruments that is used for global health security is the international health regulations. They aim to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risk, and which avoid unnecessary interference with international traffic and trade. And they are legally binding for over 190 member states across the globe. And public health intelligence, in the context of the international health regulations, considers both the all hazard, like on the one side, the all hazards approach, the importance of thinking and worrying beyond epidemics. There is outbreaks and infectious disease epidemics are very important, but also other hazards like natural disasters, earthquakes, floods, droughts, toxic releases, potential bioterrorist events are very important and are part of the public health intelligence function. Also, surveillance is one of the core capacities within the international health regulations. And the importance of integration of information from various sources, both official and non-official sources, including rumors, are a core requirement within the international health regulations. And the international health regulations also recognize the need to strengthen public health intelligence to meet the requirements for a strong early warning and alert capacity across countries in the world. Our team at the WHO Hub for Pandemic and Epidemic Intelligence has been working on a number of frameworks and guides and opportunities for colleagues across the globe, including in the African continent, to strengthen their public health intelligence skills. On the one side, we have recently launched in December a public health intelligence competency framework. We've also recently launched a public health intelligence curriculum and a free online public health intelligence foundational training for experts around the globe to gain skills on the basic public health intelligence activities and competencies needed. I will go into a bit more details and share the links for each of these opportunities. The competency framework highlights the essential public health intelligence competencies for the workforce. These competencies are illustrated through tasks in technical and functional domains, including defining essential skills and knowledge for public health intelligence professionals, and covering data collection, analysis, interpretation, communication, and policy translation. And this competency framework serves as a training tool, but also as a reference for institutions to align public health intelligence competencies with real-world needs. And you can find the link here in the slides, and I will also paste the link in the chat right after my presentation. The WHO Public Health Intelligence Competency Framework divides the key tasks in 4 technical domains based on the steps within the public health intelligence process that you can see in this slide: detection, verification, analysis, and assessment, as well as further action and response. And there is also one functional domain that covers the collaborative information exchange. We have also recently, in December, published the new WHO Public Health Intelligence curriculum. This suggests a structured training approach for public health intelligence professionals to develop necessary competencies and knowledge, skills, and abilities. It allows development through courses and learning objectives. And it aligns with the same technical and functional domains as the framework and translate the tasks from the framework into courses and learning objectives, including the 4 technical domains in the competency framework and the functional domain, as you can see in the slide. This public health intelligence curriculum can be applied by member states in the African region, either through for training and education, for the designing of new public health intelligence programs, supporting higher education courses, or for refreshment or advanced models for experienced workforce. Also, it can support organizational capacity building activities in your organizations across the globe. And I have seen in this webinar, we have representatives from many different member states, agencies, centers, and public health institutions. So it can help establishing or revising public health intelligence training across your agency or government institution. It can guide adaptation to local, regional, and global contexts. It can be applied in resource-limited or well-established settings. And the scope is modular and adaptable to the needs, roles, and experiences, and in-person, virtual, hybrid, or as self-study materials, and it can be relevant for a wide range of professionals, from public health intelligence officers to epidemiologists to surveillance staff to colleagues working across key public health departments in the different levels, both national and subnational levels. What I am also particularly excited to announce is that since yesterday, we have launched a new Foundations for Public Health Intelligence online training. This is an opportunity for anyone interested in building or refreshing foundational skills in public health intelligence in this fast-moving field. And after completion, a certificate is generated from the WHO Academy. It's fully online, self-paced, free of charge, and open to everyone. So please do not hesitate to enroll and register today and start learning. So in a nutshell, I am repeating and sharing the links here, and I will paste them in the chat. These are some of the key opportunities that the WHO have for Pandemic and Epidemic Intelligence has developed to support and strengthen capacities for colleagues around the whole globe, including the African continent, to develop public health intelligence skills. And our learning pathway can be summarized as shown, and the resources provided facilitate this learning pathway that includes the planning of the relevant training, completing these online foundations training, completing and selecting the right technical domains of interest and the functional domains, and being able to acquire the key knowledge, skills, and abilities to carry the public health intelligence tasks effectively. In addition to these global frameworks and resources, we also work in specific technical innovations that enhance and strengthen public health intelligence in the African region. And one of those is the epidemic intelligence from open sources. And maybe I can now ask for anyone to type in the chat if you have ever heard of this initiative and what's been your experience. So I'm encouraging some participation from our webinar attendees, because the epidemic intelligence from open sources is a great collaboration between public health stakeholders around the whole globe. It has a One Health All Hazards approach and complements traditional surveillance. It mitigates and prevents public health emergencies through providing tools and training to rapidly detect, contextualize, analyze, assess, and share information, connecting experts and data around the globe. And this initiative is currently present in 44 member states in the African continent. Globally, the EIOS initiative is used or has over a total of 121 countries and 31 different organizations, including the African Center for Disease Control and Prevention and many other organizations present in the African continent. As you can see here, since its inception and over the past 6 years, the EIOS initiative has kept growing and spreading further. And one key thing to consider is that the EIOS initiative has 3 pillars: the EIOS community, that are the thousands of public health professionals conducting public health intelligence activities around the globe that are part of the initiative; the collaboration. The initiative is made up of many different organizations that collaborate together to develop even further. But at the core, we have the technology, state-of-the-art web-based technology that every single day processes thousands of different sources of information, filters through all the different signals coming from all these sources, and spits out and filters based on the needs of the public health intelligence professionals around the globe, with a number of AI pipelines and semi-automatic models that facilitate the early detection of signals of potential concern. I'm going to quickly show you a video that demonstrates and illustrates some of the technology behind the EIOS system. So every single day, there are thousands of relevant news articles, media sources, posts in social media that are processed through the technological engine of the EIOS system and are made available to public health intelligence professionals around the globe. So imagine that you're interested in Ebola and vaccination in the Democratic Republic of Congo. We can, in a semi-automatic way, generate an AI summary of the key signals and articles and posts around these topics, Ebola and vaccinations in DRC, using an artificial intelligence engine. As you can see here, that's the list of articles that speak about this relevant item. And we also have what we call our EIOS anomaly dashboard that, as you can see here, is showing key anomalies for Democratic Republic of Congo, South Sudan, and Congo, with some articles being highlighted and the key analytics indicating why they are anomalies, right? Why does this AI system detect these signals as a potential anomaly. Professionals around the globe use this system every day to facilitate the early detection of potential health threats, analysis, assessment, interpretation, and rapid decision making to ensure a faster response is conducted across the whole globe. This initiative is currently in 44 member states across the African continent, and I want to thank and acknowledge our expert colleagues from the WHO African Regional Office that have been doing an incredible effort to expand in the region over the past few years, as you can see in the graph in the slides. Since 2019, 63 EIOS trainings have been conducted, most of them being 3 to 4 days, with over 1,500 experts being trained, and over 1,600 experts have completed the training online as well. There's been 50 experts mentored across 4 different countries, 67 EIOS champions selected and trained, and have gone through our 5-day EIOS championship workshop in Senegal, as well as 2 EIOS radio mining speech-to-text pilots across 2 member states in the African continent, and 1 specific publication focused on the EIOS in Africa. And here you can see a bit further of the different onboarding and phased achievements of the different countries within the African continent. As of January of 2026, a total of 44 member states in the region are part of the initiative. And one more exciting thing is that one of recent research conducted and led by our expert colleagues in the WHO African region with support and engagement from many experts in EIOS is that 47% of acute public health events in the African region were detected early through the EIOS system before official notification from national authorities to the World Health Organization. And this evaluation concluded that the EIOS system performed very well in detecting public health events in the African region early. In addition to the technology, one of the biggest strengths of the EIOS initiative and its innovations in public health intelligence in the African region, these are all the capacity building and engagement related activities in the region. Over the past couple of years, there's been our EIOS Champions workshops developed and planned for public health experts to develop their skills in public health intelligence and become champions, ambassadors, strengthening the capacity for public health intelligence in each of the member states across both English-speaking, French-speaking, and Portuguese-speaking countries in the continent. We also organize our global EIOS technical meeting in Senegal just a bit over a year ago, with over 200 participants coming from all over the globe, exchanging and sharing their expertise in public health intelligence. I also wanted to bring you a quick glimpse of another initiative that has been piloted in the African region, particularly in Tanzania and South Sudan, with this EIOS radio mining speech-to-text project that has tested a number of radio stations across different languages in both Tanzania and South Sudan, from capturing this local news, transferring those radio signals, using a listening platform that will help us understand if relevant information and signals were being reported for real-time monitoring of health threats across countries engaged in this pilot. So this is an exciting use of large language models and complex technology to facilitate, through a multi-partner pilot, to facilitate the early detection and real-time monitoring through information coming from local radio sources. So in a nutshell, and without wanting to expand much more in time, we just gave you a very quick glimpse of how we collaborate And on behalf of WHO, we are extremely committed to continue supporting public health intelligence in the African region, and particularly continue supporting the strengthening of capacities in the region. I'm leaving a few links and resources here. And I want to highlight we have a dedicated email address for the epidemic intelligence for open sources for the African region. As you can see in the slide, you can always, I will paste this information in the chat that you can always reach out to us. But I want to thank once again the colleagues that are behind all this work, particularly those that are leading a lot of the regional work in the African region. It's a real pleasure to be able to work so closely with so many member states in the continent. And I want to thank Faith and colleagues from GET for the opportunity to speak here today. Thank you so much, and I remain available for any questions. Thank you.
Thank you so much for that beautiful presentation. Please let's show some love to our speaker. Use the emoji to appreciate our speaker. Thank you for that beautiful presentation. That was very mind-blowing. And you mentioned a few things which I would like to re-emphasize. You mentioned the ways to develop public health intelligence skills, which I would like all our participants to pay attention to and not just listen to it, but then actually work on it. So you mentioned public health intelligence, competency framework, public health curriculum, and public health foundational training. And you gave us some links. You also mentioned the training that just was launched yesterday on the WHO Academy. So I would like to encourage all our participants to please go ahead and register for the course. And that was a beautiful statistics showing what the African region is doing. Wow, that is beautiful. 63 EHIOS training being facilitated, over 1,800 and 600 users have used the EHIOS training. So that is beautiful. And for the initiatives that is being done, particularly the radio mining, speech to text, that is quite a wonderful one. So I would like to encourage our participants once again, go through the courses, develop your skills in public health intelligence, and let's see how we can all contribute to ensuring that we respond rapidly to emerging infectious diseases. Thank you so much. Moving on, I would like to move on to our next speaker for the day. But if you are just joining us again, welcome. Thank you for joining. Please introduce yourself in the chat box and kindly note that you should direct your questions to the Q&A section to ensure that it doesn't get missing in the chat. So it's my pleasure to introduce Dr. Chinwe Lucia Ochu, who is the Director of Planning, Research and Statistics at the Nigerian Center for Disease Control and Prevention. She'll be speaking on strengthening public health intelligence at the national level, lessons and priorities from African experience. Permit me to go through her biography. Dr. Chinwe is a seasoned public health physician, researcher, and leader with over 25 years of experience in clinical medicine, epidemiology, and health system strengthening. A fellow of the African Institute of Public Health Professionals, she transformed Nigeria's NCDC through research governance, knowledge management, and epidemic response leadership. She has served on WHO scientific advisory groups and represented Nigeria in the G7 Signature Initiative on Mitigation of Biological Threats in Africa, SIMBA. As Vice Chair of IAS Pandemic Preparedness Response and Recovery Committee, she drives global collaborations, advancing equitable health solutions, innovation, and resilient systems. She's currently a doctor of Public Health candidate at the George Washington University Millikan Institute of Public Health, Washington, D.C., United States. It's a privilege to have you, Dr. Chinwe. She brings invaluable experience from national system strengthening and pandemic preparedness efforts. Thank you so much for honoring our invitation. We are glad to have you. The floor is yours.
Thank you very much, Faith. Quickly share my screen. Okay, so hi everyone. Thank you for joining and thank you for having me on the panel. It's really an honor to be here, and I want to appreciate the previous speakers for brilliantly speaking about most of the things on my slide. So it makes my work easier, and it's so interesting to see what has been happening in the global space and the efforts of WHO in building capacity on public health intelligence across the globe, especially in Africa. So I will be speaking, and a disclaimer is that the views I share here are my own. So we just want to reflect on what our experience has been at the national level, which I believe is also will also be similar to what many countries in Africa have experienced. And thank you, Dr. Rockwell, for that strategy of asking people to type in the chat. Please, if you feel you have a peculiar experience you want to share, feel free to use the chat for that. Or if you agree with me that what our experience in Nigeria is similar to your own experience, please engage in the chat so that we can have a more robust discussion. The definition of public health intelligence and the importance of this topic, especially for epidemic and pandemic preparedness and response, has been very much highlighted by the previous speakers. We know that most of the challenges seem to be concentrated in Africa because we seem to be the melting point for most of these infectious disease outbreaks. That is the challenge that we have to deal with, and coupled with threats from climate-related events, humanitarian crises, and even conflicts that are happening in different parts of the continent, makes it more complex to deal with infectious disease outbreaks in the continent, especially at the national level. So these events demand timely, reliable data that will guide decisions. Because come to think of it, making smart decisions depends, for epidemic response, depends on being able to access reliable data to guide the decision making for public health interventions. So public health intelligence serves as a foundational capability for early detection, improving situational awareness, and coordinating national response. I will not bore us with definitions since these have already been well laid out by previous speakers. But it's also interesting to know that when we are looking at public health intelligence and data, using data to make smart decisions, we have to look at the various components from the various pathway, including data collection, analyzing, interpreting, and disseminating the data to generate actionable insights. It's not about having data, but being able to move the data from the point of collection to the point where it is used for smart decision making is very, very important. And then at the national level, we have systems in place that integrates routine surveillance, laboratory diagnostics, event-based signals, risk assessment, and advanced analytics to be able to make these decisions. But there is still a lot of, I know we've made a lot of progress in many countries due to a lot of joint efforts, support from international partners, and even local capacity building. We've progressed from where we were before to current status where we can, we have data that we can use to make decisions. But there are still a lot of gaps. We still have gap with collection of data. We still have gap with analytics. We still have gaps with even biological data, for instance, genomic surveillance systems that we can use to track the variants that are responsible for the disease outbreaks that we're having in the country and in the continent. The ultimate purpose of public health intelligence is to support early warning systems with continuous situational awareness, as we said before, and evidence that will inform policy making. Public health intelligence, therefore, in my own definition, simply means making smart public health decisions that are based on reliable data. So looking at Africa, we represent a diverse health system capacities. We have some systems that are well established. They have well established national public health institutes, and we have also emerging institutions. National public health institutes play a critical role in advancing public health intelligence, because this is a dedicated institute that keeps an eye on what is happening. We are responsible for disease surveillance, integrated disease surveillance and response, and we are the ones that manage recurrent outbreaks that have been happening in the continent. For instance, the Ebola, cholera, measles, COVID-19, which have also tested the various systems that we have. In response to these challenges, many countries have strengthened or even established national public health institutes that are supported by regional coordination mechanisms and that promote collaboration and shared standards. However, we still have many African countries that do not have established legally mandated national public health institutes, and this is a problem. I know that this has been a priority for the Africa CDC in the new public health order. As of late 2023, the statistics may have changed, but as of late 2023, 23 out of the 55 African Union member states have fully established their national public health institutes, and that represents about 42%. With 19 that are still in the development phase and 13 that have not yet started the process. So while we have 23 that are established, only 18 of them are considered fully functional. So this is a big problem because we can't really make much progress in early warning systems and disease detection if we don't have dedicated institutes that are responsible for leading capacity building in this area and leading disease surveillance and response. I know that there are some African countries that, even though they don't have designated national public health institutes, they have departments in the Ministry of Health or other agencies that are responsible, which is fine, but there has to be a legally mandated body that is responsible for keeping an eye on these emerging threats in the continent. So that is very, very important. So some of the key lessons we have learned at the national level is that for us to have good quality data for decision making, there has to be clear governance and leadership with strong political commitment that will make it an institutional priority for public health intelligence. Data governance frameworks need to be established, and we need to have clear ways and mandates and clear agreements that regulatory agreements that determine how data is shared across the critical partners in public health decision making. Then we need clear mandates for national public health institutes to strengthen coordination across the various sectors that are usually involved, multiple partners and sectors that are involved in disease preparedness and response. So we need this clear governance. When countries that have national public health institutes that are not yet legally mandated need to come up with that framework. That helped us a lot at the Nigeria Center for Disease Control when we obtained the legal mandate and NCDC Act was passed in 2018, we noticed a lot of difference in the way we were able to conduct business because we had the backing, legislative backing to organize and coordinate the multiple stakeholders that are involved, and to also invest more in institutional capacity building that has helped us. That played out very well during our response to the COVID-19 pandemic. So this is very, very important that public health institutes are legally mandated to play their role. And for me, I would say that as much as possible, having a national public health institute that has direct access to the highest level of political decision making, like the presidency, is important. During the COVID outbreak, many countries, especially in Nigeria, we had top leadership from that high level of governance, and that helped to remove most of the bureaucratic problems that hindered access to critical resources and data to manage the outbreak. So if that model works in a country, I think that will be very, very helpful in improving early detection and response to disease outbreak. So workforce is another critical pillar, and which is a big, I think we are having issues in Africa, but thank God that a lot of things have happened. WHO Pandemic Hub has done a lot. Africa CDC is also doing a lot. And within the countries, we have countries, National Public Health Institute that have established field epidemiology training programs and multidisciplinary teams that strengthen frontline capacity. But Africa still has a lot of problems. I know in Nigeria, the issue with high staff turnover is a big problem because we're training these skilled epidemiologists and data scientists, but they are leaving the country. They are going elsewhere because of the fundamental problem we have with workforce retention. There's not enough incentive, remuneration patterns, a lot of disparity in how we compensate these skilled workforce. So Africa needs to think more about how to solve this problem. I would suggest that a state of emergency is declared on workforce retention so that countries can come up with plans, what is it, what kind of incentives, what workforce strategy should we use to retain our staff? How do we motivate people who have been trained to remain in the country, and not just remaining in the country, to be integrated within national public health institutes where these functions are performed? So it is a big gap that we need to address. So absence of workforce strategy and succession planning, we also have people that are retiring or transferring service, and there is no succession plan to transfer these skills. So that is a big challenge. There is need to keep up with evolving technology, techniques, advanced diagnostics, modeling, predictions, forecasting. We need to build genomic sequencing capacity and capabilities. There seems to be a very rapid evolution of technologies and advanced analytics, and we need to keep up with that pace. So there has to be a system in place where we concentrate on the workforce, build more workforce, and all these fellowship programs by different institutions like the WHO and others should be made more accessible to African the workforce. Systems integration is very important. We need to integrate indicator-based and event-based surveillance in order to improve our early detection. We also need laboratory and genomic integration to enhance our response. There are different kinds of ways this can be done. I remember in Nigeria, event-based surveillance has been very, very useful to us in early detection and early warning system for disease outbreaks. We have what we call the Tatafo, which we use to track important trends in the media of topics of interest. For instance, if we have cluster of discussions about diarrhea cases or deaths happening in a particular location, we're able to use these intelligence systems to track them and then investigate and verify that particular signal. So strengthening surveillance systems and moving towards integrated disease surveillance is very important. Also, we need to improve multiplex pathogen surveillance. We had a recent study that where we did acute febrile illness surveillance that showed multiple pathogens, multiple pathogen patterns in different cases. So there is a need for us to strengthen our ability to detect multiple pathogens in surveillance. That is a capacity that needs to be built, but most of the systems we have in place, like the TACMAN array systems, are very expensive, and we need to improve diagnostics that are affordable and accessible in the African context for multi-pathogen detection. Digital transformation is another key strategy which improves timeliness through interoperability and data quality, but these remain big challenges at the national level in most African countries. The challenges include systems not speaking to each other. In the One Health context, we have different sectors that have their parallel systems and a fragmentation of systems that do not speak to each other. And to be able to make decisions that will enable early detection and response to these emerging threats, it's important that the various systems speak to each other. There has to be a way of, I know there have been a lot of discussions on this, and it's been a very challenging scenario trying to determine what works for each country. How do the One Health sectors, the animal health, environment, and the human sector, how do they share data? Should there be one database where everything is located and people have access to? Or should there be APIs, that allow quick transmission of data from one system to the other? So a lot of discussions need to happen. But beyond the technology, it's also important that we look at the ecosystem, the digital ecosystem, the people that operate the technology, the context, the cultural issues, and also the governance issues that, regulate how data is shared across sectors. So these are all issues that need to be addressed in order to manage the challenges that are coming with digital technology. We need to include reimagine how African health security can be positioned through the AI lens. I'm happy that Dr. George mentioned that, and also Dr. Rockwell spoke about AI. AI presents a huge opportunity, but it also has a lot of challenges. So in the continent, we need to start thinking about how to manage AI, coming up with regulatory frameworks that will help us to take advantage of this amazing technology without keeping ourselves, making ourselves prone to the risks involved. So digital transformation is key for us. Partnerships is another key pillar that we need to look at. I know that Africa has been a beneficiary, especially at the national level, of global collaborations. So we need more regional and global partners to support capacity building, but we also have to make it sustainable, because sustainability requires domestic investment. We have to look inwards to think about what we can do for ourselves as a continent. How do we communicate data for health? There are different ways of communicating data. Science communication has to be prioritized. During the pandemic, we had issues with having the media communicating data without much training on epidemiological data communication. So we had to come up with a program where we trained media personnel on science communication, and that has been fantastic because we see the media as partners, and then we train them on how to communicate. Then scientific communication to scientific community is another way, so we need to build more skills on how to communicate data in a scientific way, either through journal publications, conferences, and other strategies. We need to adapt the audience to the audience for a specific outcome, and we also need to use all of these above strategies to target behavioral, social, and political change for health. So despite progress that we have made, we still have persistent barriers. Fragmented vertical systems, like I mentioned, limit integration, and heavy reliance on external financing is a big problem and does not support sustainability. Workforce shortages and retention difficulties weaken our systems and keep us vulnerable. We need data governance and information sharing frameworks, which are often underdeveloped at the national level. We also have subnational infrastructure gaps. Most of the times, looking at the data pathway from subnational to national, we have a lot of infrastructure gaps, like connectivity. Most parts of Africa, we have issues with internet connectivity, especially at the rural level, at remote areas, and that hinders transmission of data. A lot of our systems are still paper-based. We need to advance electronic data systems. So we need to plug these loopholes in the data pathway, starting from the community level. Participatory approaches that will build capacity at the community level and have local data governance structures that will enable us even have community partners that are able to track events and incidences that can be easily transmitted through the national pathway and plugged into the integrated disease surveillance and response system is key. We piloted a project recently at the community level using this participatory approach, and I think that is the weak end to, in our data transmission pathway that needs to be plugged. Subnational government systems, we need to build more institutional data capacity at the subnational level, at the state level, and make sure that One Health system is integrated as part of our national response. At the regional level, cross-boundary collaboration and data sharing is key. The IHR has been very helpful in enabling quick sharing of data across borders, especially with the WHO, and we have to strengthen our own local South-South cross-boundary data sharing. So what are some of the strategic priorities for strengthening public health intelligence at the national level and at the regional level? Some of the priorities include establishing and strengthening legally mandated national public health institutes, as I mentioned before, that have clear governance structures. We need to expand our advanced epidemiology program and data science training and create clear career pathways for public health professionals. In many countries, we don't have a workforce strategy or clear career pathway, that determines career progression for public health professionals, and that is a very big problem. We need to invest in interoperable real-time surveillance systems and strong data quality mechanisms that will support early warning systems. We need sustainable domestic funding, and this must be secured. I know that the African Union has endorsed Africa CDC's Africa Health Security and Sovereignty Agenda, and these have 5 pillars. The 4th pillar talks about predictable, domestic, innovative, and blended financing that will help to secure sustainable African-led investment for essential health services and health security. But we have to move from rhetoric to action. There's been a lot of talk about domestic financing, and I know the current things that are happening in the global space should teach us this lesson more, that as a continent and as nations, we need to become more responsible and more serious about our health. Because health sovereignty is our national sovereignty. And I would suggest that we reimagine the financing model that we've been using, that we transit from this donor-dependent model to maybe a business model where there is a win-win situation for both parties with a lot of contribution from the national governments. So that is the only way we can secure health security and make ourselves less vulnerable to external funding shocks. Africa must move from being a beneficiary to becoming an equal co-architect of the global health system. Yes, I'm quoting, this was one of the things that Africa CDC said, because of the continent's 1.5 billion citizens, we cannot continue to depend on external supply chains or emergency goodwill when a pandemic strikes. So this is spot on. Every country has to think about how to invest more in their own public health systems and improve domestic funding for public health intelligence. So we also need to measure our progress. We have the joint external evaluation of the IHR with the core capacities. We can measure progress using internationally recognized frameworks. We need routine indicators like timeliness and completeness of reporting. The 717 is a good framework that has been used and has been very helpful, but we need to devote more time to monitoring timeliness and also build capacity for monitoring and evaluation, integrating M&E into our programs so that we know how we're doing. We need to track outbreak detection to response intervals. So this is very important. We need this capacity at the national level in Africa. So in conclusion, we need to ensure that Africa has a stronger voice and influence in global decision-making and governance. And this will involve demonstrating innovation despite constraint. We've done that already. During the pandemic, we outperformed the expectation, and I think we can build on what all those gains and strengthen our systems more, strengthen our surveillance systems, integration and collaboration, sustainable investment, improve leadership. There are a lot of things are happening at the leadership level. We're now looking at connected leadership by AMFI and regional solidarity, which are critical for building resilience. We have to revisit the financing model. Like I said again, I cannot overemphasize this for health security in Africa. We need to think about how to retain our workforce, and this, I believe, demands urgent action. We have to build systems that are nation-centric in our partnerships, which is needed for sustainable health security. And Africa has to become more responsible for its own health. These are critical things that we need to think about if we have to improve our ability to detect disease outbreaks and threats early and to respond to them. So thank you for your time. I'm open for questions and discussions.
Thank you so much, Dr. Chinwe. Let's appreciate our speaker. Kindly use the emoji, show us some love. Thank you so much for that beautiful presentation. Yes, it is true that we have been, I can see a chat in the comments from Professor Yohale Tomari. Yes, it is true that our gaps have been our challenges for decades, and each seminar, webinar, we've always been talking about it. And despite all this, we've not had tangible changes being done. And our speaker today has also highlighted that. She also mentioned key lessons from African experience. She spoke about governance, leadership, workforce development, and particularly in the workforce development, we have a lot of our workforce moving from Nigeria to other countries, meaning that whenever we are trained, instead of us to work in the Nigerian capacity or African capacity, wherever we've been trained, they relocate to other countries for greener pastures in courts. Yeah, she also mentioned partnership, also mentioned digital transformation, and most importantly, she mentioned finances. How do we become dependent? It is not every time we have a pandemic, we reach out to the international bodies to rescue us due to the population we have in this part of the world. So this is also a call to action for us. We should stop talking and begin to work. Thank you very much, Dr. Chinwe. Thank you so much for that beautiful presentation. And thank you for our participants for staying through. We are now moving on to the last segment of the webinar. Once again, if you are just joining us, kindly use the chat box to introduce yourself, direct your questions to the Q&A segment, and it will be addressed at the end of the presentations. So right now, we want to move to our final speaker for today, the last but not the least, who will be turning to the scientific dimension of public health intelligence. I know we'll be speaking on policy, we've been speaking on implementation. So now it's my pleasure to introduce Dr. Infeyinwa Aniebo, who is an associate professor of molecular biology and genomics. She'll be speaking on the role of genomic surveillance in strengthening early warning systems in Africa. Dr. Infeyinwa Aniebo is an associate professor of molecular biology and genomics at the Institute of Genomics and Global Health, Nigeria, and a principal investigator strengthening Nigeria's surveillance system by integrating molecular and genomic data as part of the country's malaria elimination strategy. She has a BSc in genetics from Queen Mary University of London, an MSc in Applied Biomolecular Technology from the University of Nottingham, a Master of Research in Clinical Medicine, an MPH in Epidemiology and Statistics from the University of Oxford, and a PhD in Clinical Medicine and Infectious Disease from the London School of Hygiene and Tropical Medicine. She did her postdoctoral studies as a TechMe Fellow in International Health at the Harvard Chan School of Public Health, Harvard University. IFE serves as a core panel member of the Future of Health and Economic Resiliency in Africa at Harvard University and is the founder of Afrocentric, a social enterprise that supports African women in STEM. This is quite a portfolio. Thank you so much, Dr. Ify, for honoring our invitation. Genomic surveillance has become an essential component of modern public health intelligence, particularly for detecting variants, understanding transmission patterns, and also improving health risk. It's a privilege to have you here. Dr. Ify, over to you. Thank you.
Thank you so much for having me. Can you let me know when you can see my screen, please?
Yes, we can.
Okay, so good afternoon, everyone. My name is Dr. Ify Anyebo. I'm an associate professor at Institute of Genomics and Global Health, and I'm very grateful to be here. I really enjoyed the previous conversations we had about public health intelligence, and I kind of think that it really comes really nicely for me to actually present the work that we're actually doing in Nigeria at this point. So this is basically public health intelligence, I think, in practice, where we've actually focused on surveillance. So IGH does a lot of surveillance. We do a lot of Ebola, Lassa fever, cholera, and also the last COVID-19, we also sequence a lot of those parasites. But I will talk about malaria today, one of the malaria projects that started 5 years ago. And I think that it's gotten to a really good place where I can actually speak about how we're integrating genomic information to strengthen Nigeria's malaria elimination programs. So this is the content I'll be talking on, and then I'm not going to go into detail into setting aspects because I think that it might be a bit too technical, but I will cover the most important bits of this work. So like most people probably know, Africa has the highest malaria burden with about 600,000 deaths and about 249 million cases yearly. And 70% of this actually happens on the African continent, in which Nigeria suffers a quarter of that, with 31% deaths every year. The problem with this is that we also have other threats like drug resistance. So we have vector resistance happening across the globe. We have parasite deletions, which is basically gene deletions that actually happen to the malaria parasite, so that when you're trying to diagnose with your RDTs, with your rapid diagnostic test, you could actually get false results. So a lot of the times, if there is a deletion, you get false negative diagnostic test, which obviously can affect case management of malaria. Another issue we're currently grappling with is drug resistance, and our current first line is artemisinin lumefantrine combination, or the ACT. So that could be artemisinin, lumefantrine, artemether, amidaquine. So the different first line ACTs, and now we're seeing the resistance which started in Southeast Asia. We were scared that it was going to spread, but actually some of these resistance have actually shown up in other parts of the globe, of the African continent, like Rwanda and also Uganda. And not only that, we're also getting invasive vector species. So, for example, in Nigeria, we have Anopheles gambiae, which is the local mosquito that spreads malaria. But, there are also conversations about introduction of other species like Stephensi, which is a totally different vector. And so when these kind of conversations are being had, it's very important for us to focus on surveillance and understand exactly what's going on in a country and on the continent. I think previous speakers have already highlighted the importance of quality data. We don't have great quality data, and we need those quality data to make evidence-based decisions. And Nigeria currently has weak data surveillance structures, which actually hinders this attainment of a malaria target. Right now, we have 16% of malaria cases being identified, can identify malaria cases through a traditional epidemiological approach. Now, what we proposed was that, whilst we don't want to take away the traditional epidemiology approach, we want to improve on that. And the way that we can do that is integrate molecular and genomic data as part of Nigeria's surveillance systems. And in doing this, we're using whole genome sequencing. And according to WHO, intervention should not be an afterthought. Surveillance should not be an afterthought when you think about parasite or epidemic or pandemic control. It has to be an intervention in and of itself. And so we decided to focus on the intervention of surveillance. And when we approached this problem, we decided that we're not only going to do this in the lab. It's very important that what we're doing in the laboratory is communicated to the policymakers, because they're the ones who make the decision. So in effect, we're trying to ensure that we will simplify genomics so that policymakers can understand that, because scientists, a lot of times we just work in the lab, but it's important that you're sort of covering that sort of gap, and so that the policymakers understand what you're doing and that information goes to them, so you're not working in silos, it's a partnership, and they can utilize that information and make rapid decisions as to malaria control. So how we started this conversation, Nigeria always had a sentinel site where we did a lot of malaria surveillance. We had pockets of researchers. We had also the National Malaria Elimination Program doing pockets of surveillance in certain states, but we never really had a national representative collection system, is what I'll say. And so this conversation started in 2019 when we assessed all of the information across Nigeria and realized that different states had different drug-resistant profile and different people were doing different things. And so to bring all of that together, we decided to go to the Ministry of Health and just put this proposal forward to say, look, we think this is important for us to have a national representative genomic survey. But this is not something that would basically upset a structure that already exists. We want to integrate this as part of what already exists. So we have every 4 to 5 years something called the Malaria Indicator Survey, which basically helps us understand prevalence and transmission intensity of malaria. A lot of African countries do these every 4 to 5 years. So our proposal was basically trying to integrate our genomic survey in that system, so that you're not only collecting, prevalent information about anemia, information about distribution of bed nets. You're also collecting information about genomics. What does this mean for drug resistance? Does this particular drug work in this state versus does it work in another state? Just very fine-tuned detail that we felt could be very contributory to malaria elimination decisions. So for these particular projects, we set out to strengthen the quality of malaria elimination efforts by strengthening the evidence base of quality and program implementation. So in effect, we're scientists, molecular biologists, geneticists, and we're saying that we want to build that sort of bridge between us in the lab and the policymakers, because this is how I think science should literally be done. And these are objectives. We wanted to identify the parasites circulating in Nigeria. We wanted to understand if our first-line diagnostic panel, which is the rapid diagnostic test, had these deletions that would make them not very efficient. We also wanted to understand if we had drug resistance for the currently used antimalarial drugs that we have in the country. We also wanted to understand the Nigerian parasite or Nigerian falciparum genetic diversity, wanted to understand local signatures and know if something interesting is happening in the genome, because that tells us a lot of things. But all of this information was going to be used to build something that we call a malaria reporting tool. It's kind of like a dashboard that has all information on drug resistance that Nigeria has ever reported, whether that be studies that happen outside Nigeria, studies that happen in Nigeria. As long as it has a genetic aspect to it, we were interested in it. So we're going to put all of that information together with our own analysis on this dashboard that everyone can access. And most importantly, the Ministry of Health can actually access this information and use that to target the interventions. So we started this in 2021, collecting samples. We collected about 10,000 samples in 37 states in Nigeria. And we did this as part of the MIS, like I said, initially. We used something called Whitman filter paper, which is basically a nitrocellulose paper that really nicely binds the DNA in the blood. So you just put the blood in there and it binds it, and it helps you sort of keep that for a very elongated period of time. And this is important because we are in Africa. So you want to be able to keep blood samples in a very good way for a very long time. You don't want them to degrade, because if the DNA degrades, then you can't do so much analysis with that. And from that, we take that to the lab, extract the DNA from it, and then start to understand the frequencies of all of these mutations that we have identified. So just a little bit deeper into this methodology. This was during the rainy season, which usually happens between April to November. We targeted children under the ages of 59 months with their parents' or the guardian's consent. We just took a little finger prick blood because it's not really nice bleeding children. So we just took a little bit of finger prick blood. And on the right-hand side of my diagram, you can see my schematic sample of what that looks like. And we have this identifier system, have this barcoding system. So we identify exactly what states that came from, what community that came from. We know exactly the prevalence of that particular malaria on that blood spot. We also know all the important demographic information that's associated with that particular sample. And so any patient who was positive for malaria, we followed the national guidelines for treatment. And also we didn't include anyone who did not give their consent because it's very important to do things ethically. So this is just a very simple sort of like schematic of our laboratory processes. Out of 10,000 samples, 1,931 positive for malaria. What we did was isolate the DNA. Then we did something called speciation, which is basically identifying what species we have in Nigeria, because there are about 4 to 5 species of malaria falciparum in the wild. But we wanted to know which ones were circulating. We know generally that Africa has Plasmodium falciparum, but with movement of people, migration, climate change, so many things happening, it's important to constantly keep doing that. So we're very sure about what our results are and what the country currently has. Then we did something called qPCR assays, which helps us detect HRP2 and 3 deletion, which is important for us to know if our diagnostic tool works, which are the rapid diagnostic tests. And then we did multiplex amplicon sequencing. I know Dr. Professor Chinwe spoke about this, wanting to have a multiplex situation where you can identify multiple parasite or organisms at once, because again, we are in Africa, so we need to innovate for our systems. So this particular system, we innovated it within IGH, but we didn't do this for different parasites. We did this within the genome of malaria. So we knew that we wanted to target different loci for the parasites, and we knew exactly what those alleles look like. So we just targeted those. And so what you have is that it just becomes very efficient. It doesn't take as much time because it's longer to just do one mutation and do another one if you have over 1,000, almost 2,000 samples. So this multiplex amplicon sequencing was really, really a cool thing that we developed. And of course, we analyzed the data with bioinformatics tools. So some results, and when I'm talking about the results, I also just want to let you know the importance of genome sequencing and just having really fine-tuned data, really detailed data. So this was prevalent of malaria children on the ages of 59 months. And you can see the northwest of Nigeria has more higher prevalence compared to any other region. But what's also interesting is that Lagos it's almost looking like it's pre-elimination. So Lagos has it was about 3% prevalence. And then you have places like Kebbi, which had the highest prevalence in the Northwest. So when you look at this, right, if you wanted to think about malaria control intervention, of course, you're not going to use the same solution for all of it because they clearly look like they have different, they have different problems. If we want to talk about eliminating malaria, what we're going to do in Lagos is going to be different from what we're going to do in Kebbi. And this is just by way of just prevalence alone. And the beautiful thing about this prevalence data is that it's microscopy, RDT, and PCR corrected. So this is consistent across the board. In the sample that we collected, we had majority falciparum. We had some mixed infections with P. malariae in the valley. We did not have any vivax or nulci. Some African countries have started to report vivax, and vivax is generally the parasite, the vector that actually dominates Southeast Asia. And of course, if you're having that might be an issue for the treatment policy that you'd have. But it's important to know what you have. So for Nigeria, we're still dominantly falciparum with a bit of mixed infection between falciparum and malariae, mixed infection between falciparum and ovale, and also mixed infection between malariae and ovale. So just a little bit of schematic, because I thought that it was important to see in the laboratory how we're multiplexing and how we're sort of being innovative within our context. So rather than do like, markers, genetic markers singularly, or, sequencing those loci singularly, we've done this in combination so that each of our runs can identify 6 drug-resistant markers and 4 markers for genetic diversity. It just tells us how diverse our parasite is. And on the right-hand side, we added 5 additional drug-resistant markers just so that we have a really good idea of what's going on at the molecular level in these parasites. On the right-hand side are the malaria drugs that we were testing, the ones that have clinical importance. So we have chloroquine resistance, we've got pyrimethamine resistance. Chloroquine was actually banned in Nigeria, or maybe not banned, but the policy was changed in 2005 for ACTs to start being in use. But policy doesn't mean that people are practicing it, as you would see in my next slides. We also have the resistant markers, which is PF count for artemisinin resistance, which I think is very important because we want to be able to save our first line treatment. So I'm just going to go over this data was represented. This is northern Nigeria. So we have samples from all over Nigeria. But for the purpose of this presentation, I wanted to just present the northern Nigeria samples, which has total sample size of 1,140. Okay, so some sequencing results. We sequenced the mutation that confers chloroquine resistance. And what we can see is that that actually still persists. It's lower in setting states, but it's even as high as about 55% in a place like Kaduna. And despite the change to artemisinin-based therapy, we still see chloroquine resistance remains high in Nigeria. And this is what the parasite is doing. So when the policy is passed, there has to be implementation of that policy. And sometimes with the genomic information, it tells you what people are doing. And it's possible that there are cheaper alternatives because chloroquine is a very accessible and cheap drug. So people might just be, going towards that. There are also locally made herbs that contain quinine in Nigeria, and people just drink that like a tea. And so that could also be driving what we're seeing. But this is important for us to see because, we also have an ACT, artemether amodiaquine, which also can get affected by these. So it's important that we're able to target this. But all across the board, the ACTs still work in combination. But I think that this is very important information for us to see. It's important that we keep keeping track of this and seeing how this progress over the years. Then we have the second markers for sulfadoxine pyrimethamine. Now, this one is for Fansida. I think people know Fansida. I think that's the local drug in Nigeria. It's basically a combination of sulfadoxine pyrimethamine, and it's given for women in pregnancy to prevent malaria in women in pregnancy. It's also used for seasonal malaria chemoprevention, which is basically an intervention that gives children malaria tablets when it's the rainy season, just so that you reduce the number of children who actually get sick from malaria. And what we can see here is that we have really high resistance. We're already seeing partial resistance of SP all across. I mean, Jigawa looks a bit different, but when you look at places like Zamfara, Taraba, Yobe, Sokoto, Kebbi, and even Kano, you're getting really high SP resistance. And in Kano specifically, we found one particular mutation called E540K, which causes complete SP resistance. Now, this is information that the policymakers need to know, because if you have complete SP resistance in one state, you want to go back in there and, of course, maybe do another second study, because this is a cross-sectional study, but then it's a cross-sectional study that picked up a complete mutation. So this is something to worry about. So if we were supposed to do an intervention for all of these northern states, I wouldn't treat Kano the same way that I'll treat Kebbi, because I'm already seeing complete resistance. So this might actually make me think about my seasonal chemoprevention intervention for children, and also think about the IPTP, which is obviously intermittent preventive therapy for women in pregnancy. So I will be thinking about a different combination in Kano, of course, after going into Kano and perhaps doing more intense study, maybe representing different clinics and hospitals and doing this all over again to just see if the frequency of this 540K increases. If then that be the case, then I would want to know what's happening in vivo. I would want to take the step forward to do in vivo analysis to see if, people are really clearing this parasites using this SP treatment or not. And I would also want to do in vitro analysis to understand what that drug resistance profile in the laboratory looks like, because it's important that what you see in silico, which is what I'm showing you right now, is also sort of linked to what's going on in the patient's body in vivo and also linked to the in vitro analysis in the laboratory. So this is a very good way forward because it tells us that we have more work to do, but it also points us towards the right direction of what exactly we're meant to be looking for. So for this particular slide, I just wanted to show, without going really into detail on the loci and genetic signatures, I just wanted to show, two different profiles. Jigawa, northern Nigeria, at the top, Ondo State, southern Nigeria, at the bottom. When you just look at the colors alone for each drug resistance markers, the colors look different. There's different things happening here. So for a policymaker, they would want to do different interventions. And so I guess this graph is just to make the point that we have to be targeting interventions. We can't do a one-size-fits-all anymore for malaria elimination. We need to target things, right? If you remember the previous slide for Lagos needs pre-elimination interventions. We can't create a different elimination strategy in Lagos as we're doing in Kebbi. There's just two different genetic signatures and two different drug resistance profiles for both states. And this is what genetic information gives you. It just helps you fine-tune the information and helps you target your intervention. It just makes you make better decisions, basically. For the artemisinin, we have markers that we screen all over the world. And on the left, we have those validated markers. And on the right, we have other candidate-associated markers, which have been proving in so many laboratories, so many countries. They're all validated by the WHO as well. So what we normally do is check if in Nigeria, we have any of these validated markers that cause artemisinin resistance. The good news is none of these validated markers that WHO have published and other amazing papers have published, none of these are found in Nigeria to cause artemisinin resistance. But having said that, we found novel mutations on this particular CALCH13 gene. So the question then is, what are these mutations doing? So for example, we found this mutation on this particular loci of 6181, and this was found in Taraba. We don't know exactly what it does, but it's very close to another validated mutation that the WHO has published, which is a mutation in the 622 loci position. The importance of this is different countries have different drug histories, right? You have different genetic diversities. You have different treatment policies. I honestly don't believe that we're going to have to see the same thing all across the board. So if we're finding a novel mutation in our own context, then it's important that we do follow-up studies to ensure that those novel mutations are not causing the resistance that we're trying to avoid. In the way that the other lists were validated, this is exactly how they were validated. A bunch of researchers found all of these mutations and validated them. They did in vivo studies, in vitro studies, and then that was validated. So this is why this sort of genome sequencing analysis is important in the context of Nigeria, because now that we're finding novel mutations, then we can actually take this study further to determine what the actual function of this mutation is. So this is a really nice sort of summary of some of those novel mutations that we found. This, by the way, has never been done in Nigeria. This is the first ever genomic surveillance at the national level for malaria in this country that has been done. And so I'm very happy that we're able to actually identify novel mutations. Some of these mutations have been described in some parts of some other countries, but nobody knows exactly what it does. Nobody knows the impact. Obviously, still being studied, so we need to keep tabs on that. Some of them have not been reported before, but it doesn't mean that it doesn't do anything. So for example, if you look at Kaduna State, the first one, yeah, that's a 2%. In a cross-sectional study, you have a mutation at 2%, and it has not been reported anywhere, you know, and it just means that we need to just dig deeper. And this is what this does. It helps us manage, you know, first of all, manage our resources to start with, because we don't have a lot of resources. It helps us target our resources. It helps us understand what next to do in terms of tracking all of these drug resistance. And this is a very good, rather than looking for a needle in a haystack, this is a very good way to start. When we talk about the HRP2 and 3 deletion, and this is for the diagnostic RDTs, you know, you don't want to go to the hospital and then you do an RDT test and then it's positive, but then they tell you it's negative, or it's negative and they tell you it's positive. We want accuracy as much as we can have that. And this is the first study that has actually shown that in northern part of Nigeria, we actually have HRP2 and 3 deletion happening. This information was communicated to the Ministry of Health, which they're very excited about this information, and because they're able to see the usefulness of genome sequencing, they're incorporating this as part of the national malaria strategy, which I think gets released this year. So I'm very happy about this, because I think that this is just one of those things where you have conversations and with a group of professionals to say, look, we can actually have this great partnership to ensure that the silos work doesn't actually do anything for anyone. We want to work in partnerships. We want to be able to share information that can actually move the country forward. So this is one of those situations. And although the WHO has sort of like a limit for HRP2 and 3 deletion, which it pegs at 5%. Nigeria is 1%. We're not yet at 5%, but I think that this is also very good information. Well, maybe not Nigeria, pardon me, northern Nigeria, because the southern Nigeria information is kind of different. I'm not presenting here, but it's a very different thing. So the northern Nigeria is 1%, and so it's not yet 5%, but this helps us understand that we need to also start thinking about our RDTs and what exactly to do about those if they become resistant. So we're not waiting for resistance to happen to us. We're getting ready using our data to be prepared. And I think this is what preparedness looks like in the concept of public health intelligence. Another cool thing that we can do with genomics and bioinformatics and all of those cool analysis is that we can actually identify something called multiplicity of infection. It just tells us how much clones you have in one particular bite. If you are in an area with high transmission intensity, like Nigeria, you're probably getting bitten with malaria a lot. So you might have multiple clones. In a lower transmission intensity area, like for example, in our study, Lagos, or maybe another state in Southern Africa, you're not going to get a lot of clones because the transmission intensity is low. This is important for drug resistance as well, for us to understand this. If you look at the graph on the left, a place like Kano State has from 1 to 7 clones in one particular parasite. It's so many clones of this parasite going on. And the average one is between 1 to 3. So this information helps us understand the severity of the infection, the intensity of the transmission, and it also helps us with, for example, bed nets. If we wanted to distribute bed nets, how the policymaker use this information for bed nets, right? If I look at, let me say, well, I don't have Lagos here, but Lagos actually has 1 to 2 clones, just for example. I'm going to probably prioritize Kano State or Sokoto State. If I don't have a lot of money, which a lot of institutions don't have for bed nets, and I want to prioritize, I'm going to go to the high burden area. So with limited resources, this kind of information can help you prioritize your intervention and target it as well. Another cool thing that analysis helps us do is understand the transmission dynamics. Where is this parasite coming from? Where are these mutations coming from? What is the direction of the spread? In this particular sample from the northern Nigeria, we see that a lot of this transmission is spreading from actually Kebbi State. So they're going from Kebbi, spreading into other states. So it's from Kebbi going to Yobe, Kebbi going to Katsina, and other northern states. So this is also interesting, because if I were a policymaker and I wanted to control this, I'm probably going to put a lot of resources in Kirby, because if most of this infection is going that direction, that's where I want to be. So this is why this is actually quite cool, because you just kind of know at the molecular level, DNA doesn't lie. You get the information there. So you use that information to target your interventions. And this is just exemplary. This is just just a lovely graph just to show you in terms of color codedness of the resistance, chloroquine resistance. Kaduna is obviously very dark here, so it has higher chloroquine resistance as compared to, say, for example, Taraba. So again, if I wanted to change a policy that had susceptibility to any of the chloroquines, I would not be doing that in Taraba. I'll be focusing in Kaduna. So I'm just hoping that in showcasing all these examples, I'm able to show you the practical, implementable examples of what we can use this genome sequencing and the usability, the use cases of this, and how this can actually help with gathering intelligence that can help to make decisions about eliminating a disease, which in this case is malaria. We spoke about dashboard creation. It's not just enough to do all of this fancy stuff, right? We need to be able to house this in a dashboard, basically, that has historical data of Nigeria. So this dashboard has historic data from the year 2000 to today, literally. Like, we're always checking for new papers and stuff. And all of the analysis that we do at HGID also, it goes in there. So if we do a lot of malaria work, we do sentinel genotyping of sentinel sites. We do a lot of other, the other malaria programs that we do at HGID, and all of that information goes on here. And so we decided to create this dashboard because we wanted to house this for researchers, but also public policy for policymakers. And this is the first step to two steps. This first step houses all of this data. The second step is simplifying the information. At the moment, we're developing an AI tool that can help a policymaker just understand. So imagine a policymaker is in Bauchi State and says, oh, okay, well, I found the mutations, the 30% mutation in this particular gene. What does that mean? And what kind of interventions can I actually do with this? That's what we want to create. We're already creating that. And the reason for this is, if you think about Nigeria, we have, I think the previous speaker actually highlighted that, we have a lot of, talent leaving the country. But not only the talent leaving the country, you have people leaving from one organization to another. And if you train these people, they go with that training to another place. And that's not sustainable. So we thought, well, maybe a good way to do this is just have something that is central. So you have this AI platform that can help people. You don't even need to get into the biology of it. You just need to know what questions to ask as a policymaker. It'll answer you based off of the information on this dashboard that we have. So this is just one of the things that we're doing. We're utilizing technology really nicely. We're also really keen on ensuring that we use a lot of the AI that can help us automate certain things. But I think that the training aspect is also very important, because when we're losing public health officials to other organizations or other countries, we don't want them to go away with the technical know-how. We want the technical know-how to have a platform, and anyone can go there and take the course themselves and then ask it what it means. If they're in the field somewhere, they can still be able to access that. And another aspect and feature of this is that you can use this without internet connection. So we're also utilizing that. So you can use it with internet connection, and you can use it without internet connection, because, if you've worked in Nigeria before, or any African country, and you go to the rural area, it's kind of neither here or there. If you want to get really good internet connection, can be difficult. So that covers that. So just to conclude really quickly, we do have presence of drug resistance mutations for commonly used antimalarials in Nigeria. We do not have the validated or the described CALT13 that confers artemisinin resistance. However, we do have novel mutations, which we are very eager to explore even further. So from my presentation, I hope I was able to show you that different regions of Nigeria do have different genetic susceptibilities and genetic signatures, and so should have different sort of genetic profiles, so then should be targeted. So the interventions there should be targeted. For the PFHRP2 deletions, for the diagnostic resistance, the WHO spec that to 5%. We only found 1% in our study, but it means that we just need to keep a really close eye on that. And I think that surveillance and continuous monitoring is definitely needed so that we ensure that the case management for the diagnostic tool is very effective. And quality data, of course, is pivotal to making rapid and evidence-based decisions, which is needed for malaria elimination. Thank you guys so much for your attention. I'm very happy to take any questions. Thank you.
Thank you so much, Dr. Ify, for that well-detailed presentation. Right now, we'll be moving on. Please, let's show some love to our speaker. Use the reaction, the emojis to appreciate her. Thank you so much. So right now, we'll be moving on to the question and answer segment and the interactive section. But because of our time, we might not be able to do that as much as we want to. I can see that we have our questions has been answered already in the Q&A box, but we have one more question, I think two more. And I can also see that some interesting conversation has been going on in the chat box. And I would also like to invite Professor Yewale Tomori to say one or two things if he is able to speak. Professor Tomori, Professor Tomori, if you can speak, please go ahead.
Okay, can you hear me now?
Yes, we can.
Thank you very much, and thank you for all the presenters. Great work going on in different parts of the country. But like Chinwe knows the way I feel about many things that we do in this country, I think none of us is stressing the importance of the fact that we have to use our money and get away from these donors. They may be useful to you now, but they're not useful forever. You must get your own money and do your own thing. And when you talk about win-win situation, win-win only comes when you put your money into your own problem. Nobody is there to solve your problem for you. If they're solving your problem, they are actually looking more for their own problem to sort it out. I think time has come for us in our different countries. Let's talk to our governments. Yeah, you guys are doing great things, but you're doing it with donor funding. How much of our national money is coming to what you're doing? All those of you have been talking today. How many of Nigeria's money comes into what you're doing? Maybe your salary. Even that one, sometimes you have to borrow money from World Bank to do that. So I think time is coming for us, we as scientists, to come out and begin to make that message to our governments to put money into our research. You remember the last time when Trump coughed up his money for HIV? Isn't the same Nigerian government announced that they were able to get $200 million to offset some of this? And I asked the minister, where was this money before? He was looking at me. I said, if the Trump had not said what he said, what would we have done with the money? He was looking at me. These are the things we need to be getting done. We talk about capacity building. They've been building my capacity since I was 80 years ago. We are still building capacity. We should be retaining the capacity we have, and it's us that we do that. So let's get, I mean, you can talk all the fancy things you want to talk on your webinar. When you don't get down to the basic nitty-gritty of getting your government to put money into what you're doing, forget it. We'll be talking the same volume now. 10 years from today, we'll be saying the same thing. Over.
Thank you very much, Professor Tomori. Thank you very much. That is true. We have to start action and stop talking about these things. So right now, I would like our speakers to answer some of the questions here. Is there any connection between EIOS and area initiatives? Also, we have, how can we increase the credibility of EIOS data, especially from social media such as Facebook? Over to you.
Thank you very much, Faith. Thank you very much, colleagues. And maybe I want to start saying thank you to all the attendees that have been asking very insightful questions and great comments received. It's fantastic to see such interest. So regarding the question on the credibility, and all of us profiling health professionals, we are currently in a fairly challenging era where more and more disinformation has been spread across media all over the globe. So it's a challenge that we are all having to face. Within the ARIS initiative, we've set up a number of features that can facilitate the filtering and analysis and insightful generation of insights based on those signals and information that is being detected. It will always require the final expert judgment of experts to determine the confidentiality levels of each of the informations and signals of interest, but we are trying to facilitate through this automatic detection of key categories, topic, sources, source type, and also even the tone and intent in the message provided. So it remains a challenge, particularly in this very complex geopolitical era, but it's something we're trying to contribute to and facilitate the role and activities of our public health professionals. Regarding ERA, and for those that might be a bit less familiar, it's regarding this initiative that has helped supporting some of the social media listening and with a particular focus in the African region. We've had quite a number of discussions, and one thing to highlight is that the EARS initiative does include information from a wide range of sources. But in particular, from social media, we are not focusing on social listening as such. We are focusing more on official sources and official blog posts, and not on monitoring the rumors or trends that might be spread by personal media sources. So there is a connection and opportunity to complement each other's initiatives and activities. Again, a huge thanks for the opportunity to be here and the great questions. Over.
Thank you very much. Thank you for that response. I don't know if our other speakers, Dr. George, Dr. Chinwe, you have any closing remarks? And I can see there's a question directed to Dr. Ify. He says, is there any plan for the Institute of Genomics and Global Health to develop malaria vaccine moving forward? Over to you.
Well, thanks for the question. We already have a malaria vaccine. You have the R21, which I think is quite efficacious. We've got two malaria vaccines, actually. The second one is going through clinical trials, I think, in Ghana and a few other African countries. So what AgeGID is doing is we are interested in developing vaccines for other infectious diseases, but for malaria, we're more interested in developing diagnostic tools. So diagnostic tools that allow us efficiently target the drug resistance spread, diagnostic tools that helps us track the spread. And a lot of that is basically laboratory-based diagnostic tools that we think that a lot of institutions and public health organizations can actually also use. So that's kind of where we are.
Okay, thank you. Dr. Judge, you want to say something?
I just say that the benefit of these kinds of multi-data surveillance systems is that they're not dependent on any one stream of information, and that therefore, when you get bad information from one data stream, one of the questions was about what do you do about the inaccuracies? They pointed out Facebook, but that's the same with all of the data streams. Um, you're not dependent on it, and so like any other piece of intelligence, what makes data different from intelligence is that you've actually analyzed it. And so you can rule out and eliminate or at least minimize the amount of distraction you get from bad information by understanding where the data came from, looking at data that is more valuable because it can be trusted over other data. Does not mean that even a bad rumor can be right a couple times a day, as they say. Broken clock is right twice a day. So even a bad rumor can turn out to be factual at some point. It started out as a rumor that wasn't accurate, but it did pick up some kernel of truth. So You just have to really understand where the data came from and do a good deep dive into whether you can trust it or not.
Thank you. Thank you for that beautiful response. Dr. Chinwe, do you want to add something to?
Yes, thank you very much. I think we've been building capacity in Africa, like Professor Tomori said, data analytic capacity and all those. But if we don't do something about workforce retention, because we are bleeding workforce in the continent, and this is an issue that we don't seem to be focusing enough on. If we don't do something about that, it's like pouring water into a bucket with holes, So our capacity building efforts will just be losing them as they are coming. And this whole thing is tied, of course, to domestic funding for health and for workforce building. It has to come even from African Union. It has to start from there, because when you see Africa CDC with a domestic funding strategy looking for funding from outside of the continent to implement that strategy, then that tells you something is wrong. So we need to really look inwards and see how we can, as a continent, invest more in our own health and do something really about the workforce problem that we have. I think it's an emergency that needs to be addressed very quickly. Thank you.
Thank you very much. A big thank you to all our speakers. Please let's use some emojis to appreciate our speakers. Thank you, and thank you very much for honoring our invitation and for your beautiful insights. We're now coming to the end of the webinar. Such a great one, and I'm sure we all enjoyed the sessions. So the slides, the presentation slides will be shared across alongside the webinar certificate with the permission of our speakers. If they allow us to share the presentation slides, we will do that. And I would like to thank our participants. Like we usually say, we do not have the guest webinar series without the participants. It is because you are joining, that is why we have this webinar every month. So we thank you, and we thank our speakers again for your time, your expertise, and your thoughtful insights. Like it has been said, public health intelligence is more than data collection. It's about system, it's about governance, it's about workforce capacity, and above all, translating information into timely action. So thank you so much. On behalf of the Global Emerging Pathogens Treatment Consortium, we want to say thank you to everyone that joined across Africa and beyond. And I'm also extending greetings from our Chief Operating Officer in person of Dr. Ayodetunbo Badoye, who is unavoidably absent. He would have loved to be here to be a part of this beautiful discussion. But regardless, we would always meet again. Your engagement has made this conversation beautiful. So we look forward to seeing you by March, and please stay connected to get on all our social media platforms. I believe the link has been shared at Get Consortium. And the recording of this webinar will also be uploaded on our YouTube channel at Get Africa. Thank you, and thank you again. Good morning, good afternoon, and good evening, wherever you're joining from. Bye.
Thank you
Beautiful
very
moderation,
much.
Faith. Thank you. Thank you,
Great
everyone.
job. Thanks.
Thank you.